primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care allows me to give the kindness, respect, and attention to my patients, as well as myself and my family. I'm Dr. Tom Rountree with Clear Health Medical, and this is my DPC story.
Dr. Tom Rountree is an urban family medicine doctor. He attended the University of Houston for his undergrad and then A.T. Stills University for medical school. He did a year of OB-GYN, then switched to family medicine residency at Henry Ford in Jackson, Michigan. He is also a proud husband and father of his 4-year-old son, who consistently challenges him with single leg takedowns. Welcome to the podcast, Dr. Rountree.
Thank you so much for having me.
This is such a treat. I know you've been listening to the podcast for quite some time, and now it's the time for other people to hear your story. So I wanted to start off with, earlier in the season, we heard from Dr. Harris, who's also in Michigan and who also was a chemical engineer. So I wanted to get started with just this amazing journey that we all have. We go to undergrad, we have all these majors. I was an anthro major, an evolution major, and we end up choosing different things compared to what our majors were. So science, there's definitely going to be overlap, but can you share with us how you went from a degree in chemical engineering to choosing to be a physician?
Yeah, sure. So it's kind of a convoluted way, but I was a chemical engineer, but at the same time, I was also a professional classical guitarist. And so what I would do was I would go, one, I would raise money, and two, I would go to hospitals and just play for free, play in the middle of the hospital, and people would sit around and people would invite me to their rooms and say, can you play for my daughter or my son? They're sick. So, I started sitting there and realizing, maybe I could do a little more. And I'd always been interested in, at first it was kind of like biotechnology. I got accepted to UT for like their master's program in biotechnology, but I didn't go because at that time I had decided to go to medical school. But it was sitting in these hospitals and meeting these people and being able to get face to face with them that allowed me to really understand that I wanted to make that decision and bring a little bit more humanity into my life. As a chemical engineer, you're working with machines. It can be dangerous. And instead of saying, hey, I'm just going to stick with chemical engineering, I decided to go into medical school and kind of seek out a little bit more, humanity in life.
So it's not so surprising that, initially when you were in medical school and training, you had thought about becoming an OB-GYN, taking care of the dyad of the mom and the baby. So how did you, from this place of love the humanism in medicine, I could totally do this, I have the ability, the smarts, the desire, the everything to do this job as a doctor, how did you then transfer your thoughts and focus from OB-GYN to family medicine?
Yeah, so I started out in OB-GYN, and it was almost a rude awakening for me because I was initially in medical school that's in the middle of nowhere in AT Stills, and the OB-GYN doctors there, they weren't delivering 100 babies a week, right? And then I get to residency and it is like a full-on production, right? I'm delivering babies left and right and getting in on C-sections, and I'm loving it. Like I'm kind of loving it. But then I start to realize, well, I don't really like being woken up so many times at night. And so I talked with my wife about it, and my wife, at the time, she's in her general surgery residency. And we thought about it. We go, wait a second, if we ever want to have kids, they will never see us, right? If she goes into, now she's in vascular surgery, but if she goes into that, then it's going to be extremely difficult on both of us. And so I had decided when I was in the ER, I was treating a little boy and another guy at the same time and a lady. And I was like, you know what? I really like the a little bit broader depth and a little bit more investigation work. In other words, figuring out what the underlying problem was. And so I thought to myself, I really want to treat not only women and kiddos, but I want to treat men too, right? Because in OB-GYN, you do kind of see the kid and you kind of make some suggestions on what their feeding habits should be and stuff like that. But I really decided that I should treat a broader spectrum of patients. So I went to my director at the time, fantastic guy, and he was like, "What?" He's, "Oh my God, you're gonna," he's like, "Tom, if you don't get in that residency or family medicine, you're gonna, your life is gonna end," right? That's how he kind of put it to me. And I was like, well, I've done a lot of things, and if I have to fall back on my previous degree, I guess I will. But I didn't want to be unhappy anymore. So I decided to make that switch, and I got into a fantastic residency in Jackson, yeah, Jackson, Michigan. And there I got to see a whole spectrum. I got to see, we have a large prisoner population there. I got to still deliver babies and open a chronic pain clinic, start up ultrasound, all kinds of cool stuff. So that's how I kind of decided to transition over there.
It's so wonderful to hear that, and I think that it also is so important for people to hear that because people like Dr. Adam Schulte have, dreamt about ortho and become family medicine, become a family medicine
Hmm.
doctor, and have done amazing things in their DPC. ER doctors like Dr. Pete Cascio, Dr. Brian Ostick, who have also been on this podcast. They've gone from 100% ER to doing DPC as
Mm.
part of their careers. And so I think that especially if there are listeners out there that are thinking that same thing, that I love the continuity. I've done training, I've done decades in the field of fill in specialty here, and I want to transition. That is still very possible. So tell us, though, especially for those medical students and residents who might be listening, how was the transition to your family practice residency? Because we've just had the every year when the match comes, people are
Yeah.
freaking out about, will I get matched or will I not get matched? And those people who do not match, they are still able to find positions. It might not be in their ideal specialty or their first choice specialty, but how did that process go? Because it wasn't during match or soap time, it was during from residency
Hmm.
to residency. How did you find a spot? How did you find a spot that was ideal for your living situation so you didn't have to move? And how did it work that you
Yeah.
could transfer, so to speak, your training years into family medicine?
Right. So there's a lot of considerations there. So one of them was, how do I find it, right? And I just got on the phone and started calling. I was like, I called all the residencies I had rotated through, because I think I rotated through, at that time I'd rotated through two other family medicine residencies. And so I called them. I was like, hey, this is where I'm at. And what I did was, before I decided to transition out, uh, I made plans to actually go through family medicine residencies. So I was like, okay, I don't like this as much as I thought. Let me set it up to where I can at least somewhat try and win the game, win that transition. So I literally started calling them, and it worked out pretty well because when I did go into family medicine, I had that strong kind of surgery, chop chop background, right? We're going to go do this and we're going to get it done. And this is what we have to do. And so that really helped, especially like on nights when there were emergencies. I remember I had four things going down at once, people trying to crash on me at once, and I was running all of them. And it really helped that I had this OB-GYN background because in surgery, it's a little bit more higher, like acuity, right? And I was able to do these actions, and it actually really helped me out a lot. And I decided to formulate my new, because I had to apply again to that residency. So I had to rewrite my essay or my summary. And so that kind of helped a lot. But yeah, that's kind of how I did it. So I kind of set myself up to transition well over there.
Amazing. And as you were going through family medicine residency, what was it about the residency that really solidified for you? Like, totally, this was the right decision for me.
Oh yeah. So it was, I guess, one, they had an amazing call room that they had redesigned and everything for the residents. And an amazing like sitting room where you could type all your notes, and it was completely separate kind of from the hospital a little bit. So it was really nice. The director, she was very welcoming. She was like, "Oh, I know where you're coming from," and all that good stuff. And she was very open to the fact that I was coming from OB-GYN, and she was really nice. She was not really strict, just really open. So that helped a lot. And the fact that they had the prison population. We had a wing on the hospital that was the prison wing. One door would open and you'd go and lay your phone down, and then the other door would open and then you'd go through. So that was really cool. But yeah, and it was like it was a smaller town. So I could really know the community, and I could walk to the hospital too. It was 2 hours away from my wife at the time, so that was really hard. But we were both busy, so it didn't really make a big difference.
When you were in residency, you were getting closer and closer to graduating from residency. At what was your journey like in that last year of residency in terms of looking for positions, or did you always know that you were going to open up your own clinic?
So yeah, so I had always known that I was going to open my own clinic right when I was in medical school, because when I got there, I had asked the one of the doctors was complaining about insurance, right? And in the world of business, because I had owned a couple of businesses before med school, and then I sold them and I went to med school. And so he was complaining about insurance, and I looked at him and I said, well, why did you just not take insurance, right? I had no clue, right? No clue, right? I looked at him like he was dumb, and he looked at me like I was dumb, right? We are both kind of dumb, right? Because it was like if somebody is just completely taking advantage of you, then you got to stop, right? Otherwise, you're gonna suffer for a long time. So I'd always known I was going to open my own clinic at that time, because I realized how big of a burden it was for with insurance. But my wife was going to she was doing her fellowship. She was going to go do her fellowship. So I was looking for jobs for 1 year, and then we were leaving to Columbia, Missouri for her fellowship. So I looked for jobs, and right off the bat, the hospice center in the area was going to hire me because I was really good with hospice. I like to sit there and listen to them. And they asked if I wanted to be director, but it would still be 2 hours away. So I said, I really want to be close to my wife. I miss her a lot. She's fantastic. And so I went and I got a job, and it was very interesting because the advertisement for the job said, "Oh, look, you only see 10 patients a day." And I was like, "What is this?" And so it was home visits. And so I did home visits for about a year or so. And the problem, though, was their technology was awful, and they knew it. Their EMR was awful. And even their new director that came in, he's like, I know I got to get rid of this. But we couldn't even see 10 patients a day. We could see maybe eight or something. But that's what I did. I did home visits for about a year, which is very fascinating because it takes you into their home. And I got to do a lot of things. I kicked in a door one time because the patient she was not responding. and we knew she just got dropped off from the hospital for CHF. So the manager of the apartment complex was like, "Can you kick in the door?" And I was like, "Yeah." And so we did, and she was on the floor, and I got to rescue her. So that was kind of cool. So yeah, I did home visits for a year, and then I actually worked for a large corporation for about 4 to 6 months, just as COVID was starting, and that's when my son was born. So yeah,
I will say that 100% I never had to kick down a door during
yeah,
home
yeah,
visits
yeah.
for in residency nor at our practice at Big Trees MD, but my goodness, I think that that's really crazy to hear about home visits. And I'm assuming you were doing insurance at that time.
I
You were,
was,
yeah.
yeah.
Uh, with that said, we know that the codes, the visit codes are going to be different from an in-office code versus a home visit, and the reimbursement's definitely different. So how did
Mm-hmm.
that work out knowing that you came from a spot of like, why don't you just not take insurance? You thinking that you were going to open up your own clinic and then finding because this is the job that filled the bill for the time that you needed it to, that you were in this insurance world, not only in the home visits, but that 4 to 6 months with the second company before opening your practice.
Yeah, so that was it was basically all the horror stories that you hear because we would meet like on Fridays or something in that company, the home visit company, and there would be metrics all over the board, right? And then they would compare you to your peers. And I would just immediately bring up the fact that the EMR was bad. It sucks, right? And so they did not like that. And but that's how I've always been. I've always been like straightforward. And so, but that's how it was. It was like you were a kind of a metric, like your total sum of your degree and your life and your interaction with patients was listed as like a number on the board. And it was pretty awful. And it was such a contradiction because at one point you're helping people inside their homes and I'm sitting there watching maybe a soap opera with one of my patients. And at the same time, in the back of your mind, you're like, well, I'm never going to get to check off or get rid of the diagnosis this patient stopped smoking or something like that, right? And so that's always in the back of your head that you'll also be compared to your peers as well, which is just it's a pretty inhumane thing to do. First off, because everybody's a pretty good individual, right? We experience the world as an individual, we see it, we do things differently. And that's what everybody else wants, right? That's what the patient wants. They want to be treated individually. But yet you have this standard checklist that they teach you in the beginning how to do it. Like they had a model makeup of a home, like a room in a home, and they would walk you through, okay, medications come out first, you do this. And it was kind of like a cog in the wheel kind of method. So I got to see really eye-opening fact that I had heard about but hadn't seen yet was like all the metrics compared against. So yeah.
So I have to ask there because it sounds very OSCE. I just the whole checklist of make sure you wash your hands and then greet the patient.
Hmm.
Like everyone who's been through OSCEs through step two knows like what that life is like. But when it comes to your first job out of residency, getting a taste of this insurance life, getting a taste of how I just sit here thinking that's impossible. Like the number of home visits I've
Yeah.
done, there's not a single time where there was there was a formulaic way of visiting a person. And especially like you're talking about in the beginning, you wanted to bring humanism to medicine that only you could bring as a doctor by becoming a
Hmm.
doctor. And here you are like I'm supposed to be taking good care of a person in their place of probably the highest vulnerability in their own home.
Yeah.
And I'm given a checklist. And how did you last until you
Yeah.
transition to that next job? Because and then as you talk about like layering and Dr. Rountree is now being compared to Dr. Smith, and the
Mhm.
codes that they're bringing in is very different. How did you last that time that you needed to until you went to your next position?
So what had happened is the manager there, he was a fantastic guy. and he would really try and work with us. And I mean, he became kind of my friend a little bit. And he knew the suffering that this imposed metrics from, I think it was, yeah, Medicare, right? Yeah, Medicare. And he knew that it caused that suffering. And so at all times he would try and alleviate it and joke with us and things like this. But in the back of my head, I'm like, well, if you're a large corporation with multiple sites across the country, what are you doing about this? Right? Like, why aren't you just, again, why aren't you saying no? Right? Or why aren't you lobbying in government and things like that, which they didn't have. And so he being there kind of helped me a little bit. I wasn't plowing through 20, 30 patients a day. So I was like, okay, it's better than that. But there was some point where I was like, okay, I've had enough. It's time to go and change jobs, which I did. I found a much better company that was more respectful to physicians, owned by physicians. And I did that for the next 6 months. So I think it was like a total of, I want to say, a year and 3 months that I worked in the industry like that, like the corporate industry. So yeah, that's how I kind of, and plus I mean, I exercise, I do jujitsu, and so those avenues of relief, and I meditate all the time. Those avenues of relief really helped me out, and so did my wife too. Like she's such a champ. She helped me out a whole bunch, and helped me through it, even while she was in residency, which is kind of crazy too. So.
Knowing that you had this desire to open up your own clinic and knowing that you were not the biggest fan of fee-for-service medicine already, even before you took your first job out of residency, at what point did you decide DPC is going to be the way for me versus just pay me for every single visit with cash rather than a membership?
So I knew that I wanted to do this model. I just didn't know if I wanted to do like straight cash pay or membership model, right? And so I got onto YouTube and I was like, "Oh, okay. So these physicians have figured out something here that seems to work really well." And so I was like, "Oh, I can do that." Right? I can create a website. I can do Illustrator and craft my things that I need, my marketing and stuff like that. And so that's how I first found out about it. And then I found the DPC mapper and I was like, oh, these people around me are doing it. So it's a viable thing in this Michigan market. And then I found Paul at Plum Health. And I was like, oh, this guy's a rock star. He's killing it in Detroit. So I invited him actually to my residency. And so he came and showed up. And so that was fun talking with him. But I also did in my residency, my entire in project thesis was direct primary care. So I presented that when I was graduating to my attendings and stuff like that. And they were very curious, right? And none of them had ever started a business before. And they were they were like, well, what's one piece of advice that you'll give somebody who's just starting a business? And I told them, I said, well, it's going to be the most scariest thing you do, but it will forever be a lifelong achievement and journey that you will now take with you. And those things that you learn will never go away. And so that's how I learned about DPC. And I just started working on a name. I did a name, I did the colors, and I did the website. And so that's how I started out, and the rest is history.
Amazing. And let me ask you there, in terms of you even thinking about this during residency, which I wasn't aware of. So that's amazing that you learned about it so
Mhm.
early on. And you, with your wife finishing and transitioning to fellowship, finishing her residency, transitioning to fellowship, with you taking these insurance jobs, I want to ask about how you planned for your DBC apart from the website, the marketing, the colors, in terms of financial resources, because with a fellow is going to make more than a resident, fine. But with you having a real post-residency job and her having fellowship income, how did you financially plan to open your DPC. And did you guys already know that you were going to be moving back to Michigan after she finished her fellowship?
So we didn't know we were going to move back. And what I was doing at the time was I was working in a regular insurance physician owned practice in Columbia, Missouri, while she was doing her fellowship. And I was making great money. I mean, really good money actually. And so I used that money to buy things that I would need for the practice, and including things like I bought like a reference software that we all use. I bought 3 years worth of that, right? So I took the softwares that I had tried and tested, and then I just bought the long-term plan for those using my insurance-based practice money, right? So that way it persists until now, and I don't have to pay for it. So that was one way that I did it. And then I sought out ways like to look for what's the cheapest way I can do this. Because everybody says all you need is a stethoscope and like a laptop, which is pretty true, and a large room, right? So I decided that I would share with another doctor. So that was the first thing I started doing and looking for when we moved back to Michigan. But then when she graduated, now she's vascular surgery. So she just gave me money, right? So she just gave me that money to continue the practice and pay for the practice. And then that got smaller and smaller as more patients joined. And so that's how we kind of funded the practice, was doing it that way.
Amazing. And now let me ask you about your journey as parents, being a two-physician household with a son. He was very little when you guys were transitioning from fellow in vascular surgery to a vascular surgeon, and with you transitioning from an employed position to your own clinic. How did your journey go in regards to parenting? Because you were moving from place to place. I'm not sure where your guys' parents are, but how did you make that journey happen while still being able to be present for your son?
Yeah, yeah. So oh man, that was difficult because my wife will attest to it. It's when she's in her fellowship, I'm a single parent father, right? Except I don't have the natural resources to feed our son. So she would come home and take care of him for a little bit and then go back to the hospital. And so I had to learn how to kind of take care of him and soothe him and all that stuff. And then now, after she's graduated her fellowships, and now I'm doing the clinic, the role is reversed a little bit. Now she takes a lot more care of him while I'm like trying to build the practice and things like that. And so, but we had to make this concentrated effort to be like, okay, I'm home now, and maybe I'll work out for an hour, but then after that, like it's his time. I have to pay attention to him, put the phones down, close the computer, and pay attention with him and whatever he wants to do in the moment. And even if it's like wrestling and punching me in the thigh, that's what we're doing. And then trying to get outside more with him, making that a point. I think he even meditated for two whole seconds one time, so that was great. But now it's a little bit better now that I'm not as frantic about getting more and more patients. We can spend that time together with him. And now he has friends in the neighborhood and they play with him. So it works out pretty well. But it was tough. Like no joke. It's tough when one person works and the other person is trying to build the clinic.
Well, thank you so much for sharing that because I'm sure a lot of listeners can relate to that or their fears of becoming a parent and doing a model where one or two people are in direct primary care. I'm sure that that speaks to their concerns and their fears. And I think that it's helpful not only to hear how you and the other guests have done DPC as a business, but also how you manage your lives at home because you're a DPC doctor. So, with that, I want to ask about your decision to be a solo doc versus joining on to another DPC. With you looking at the other DPCs that there were in Michigan, had you given consideration to joining a practice versus opening your very own, even though early on you knew you were going to open your own clinic?
Yeah, so I looked at other practices in the area, like Paul's practice, right? He's growing like gangbusters, and he he had an attractive offer, right? Nice new clinic, all that good stuff. But the problem was the drive. Like I wanted to be as close as I could to my house because there's a strong correlation between happiness and the amount of distance you have to your own business or wherever you work. So that was always on the forefront of my mind. And plus, I had been developing this idea just for a really long time and how I wanted to practice and do things. And I think working for another DPC is great. Like if you want to do that, and maybe that's where you start and you stay there for like 5, 10 years, and then maybe go run your own, right? That's always possible. But for me, it was that I had grown this little baby, and I was like, oh wow, I really like this idea. And so that's why I wanted to keep it my own. And plus, I always find that it's a little bit quicker if I want to implement something new. Like I just implemented using mindfulness, like teaching mindfulness in my practice. I have a course and all this stuff. And I always found that like that is way easier to do if you're on your own. If versus having a business partner or somebody over you, if you just do the thing and you instead of just looking at the path, you actually walk it, then it seems just to be a lot easier, a lot faster. So that's yeah, that's why I stuck with my kind of solo doc.
Amazing. Now, you had already the logo, the name, the website. When you were getting going, when you were starting to tell your community, "Hey, I'm here, I'm open, I'm totally available for new patients to join on." One of the things that you had done early on in your journey was being involved at the Healthy Living Expo. So, can you talk about what was that experience like and how your clinic benefited from your involvement at that expo?
So the Healthy Expo, it did not go well because most of those people that came by, really nice, but they were in the Medicare range. And so at that time, and still, I'm not doing Medicare. So they were like 65 and older. And I think it was probably the time of day, I think for the Healthy Living Expo, I think that was kind of a problem. I think it was during like work hours or something. And I met a lot of cool people and interested stuff, but the age range was was out of my patient panel range. But one of the coordinators said, "Hey, I want you here next year. Can you do vaccines here?" And I said, "Yeah." I said, "I'll do vaccines there for sure." Because the supplier who was supposed to show up, they didn't show up till it was like 2 hours before the expo or an hour before the expo was supposed to be over. So that worked in my favor. So it helped in the fact of networking, like business networking, but not so much as the patients, which I think both is extremely valuable. Those business relationships, you can always go back to them and always talk to them. And it's usually more than you think it is, right? Like they'll come back later and say, "Hey, I thought about you here. Do you want to give a talk here?" And so I think that even if you think it's like a waste, like I said in the beginning, I still got to meet a lot of people and I still got to network, which is extremely important.
Awesome. And let me ask you there because I know there's listeners wondering this as well. When you mentioned that you have not yet opted out of Medicare, is that for a particular reason or is that because you're going to plan to opt out at a certain time? What's the reason that you haven't opted out of Medicare quite yet?
So it's probably because I've just had other projects that I worked on. And plus I've had like people join. Like it's been like a little barrage recently. And plus I've been working on, or I was working on my mindfulness course. So I was just devoting my time into other areas. But I think I'm gonna give them a call and say, hey, how do I opt out but still be able to prescribe and refer people? Because I know I can because I talked to them before. Something had happened with my Medicare. number or something, and I had to call them. And they're really fantastic in Michigan. She's a really nice lady and knew what she was doing. But yeah, I just had other things that have been going on. I just haven't gotten around to it. And that's basically, and I probably need to because I think this population where I'm in, we have a ton of retirement homes. So it's probably to my advantage to actually do that.
There are some issues with people prescribing something like a medication or an IUD, and then you'll have the insurance say, oh, because you don't accept our insurance, we're not going to approve your prescription or your IUD prescription for patient. But in terms of when people opt out of Medicare, I have never had an issue with another doctor who does accept Medicare saying no to the business that I'm sending them. So definitely putting this out there. If anyone has had that issue, go to our contact page at mydpcstory.com and let me know, because I have not had, I don't think I've had any guest on the podcast share about difficulties there, which I hope gives people hope if they have that as a fear opting out of Medicare. So now with you focusing on, like you said, you have a mindfulness course, you're I think that's awesome that you're respecting your boundaries as to this just didn't hit my plate yet because I was focusing
Mm-hmm.
on other things. One
Yeah.
of the biggest things that you are very passionate about is taking care of yourself in terms of having a good lifestyle and modeling that for your patients, and then also helping your patients practice good lifestyle medicine habits and techniques. So,
Mm-hmm.
how did you start infusing that way of focusing on full body, lifestyle focused medicine into your practice because this was all yours and you could do what you wanted with it?
So the lifestyle medicine, I'm part of the American College of Lifestyle Medicine, but I had always taken care of myself, and really, I've always worked out, and I've always done meditation since I was younger because my dad taught me that. And what I started doing was slowly putting it into the plans for like hypertension, right? And I would tell people, okay, go look up mindfulness training and see what you think about it and stuff like that. So, so that's what I did. I looked at avenues of how do I incorporate this into my treatment plans, and that's why I found the American College of Lifestyle Medicine, and they have a bunch of really nice modules and teachings about it. And then I just started I was like, well, how can I give my patients better access to this, right? How can I do that? So I created a course on it. And so then I could give it to my patients and charge them much, much lower than a regular mindfulness course would cost. And then they could ask me questions about it and use it to help lower their anxiety and depression and blood pressure. And so that's how I slowly started doing it. And I would ask people, you had to ask the question, what do you think about alternative medicines, like or alternative treatment plans, like mindfulness training, like meditation? And sometimes you run into certain barriers. People have certain ideas about it that you have to respect. Some people ask, is it a religion? Which certain aspects of it are not. So that's how I kind of started to integrate it into my plans. And then I would also send them cooking plans and meals. I'd say, okay, try cook this one meal this week, right? Just one. That's all I'm asking, just this week. Make some salmon with asparagus and put some Grey Poupon on it and put some garlic on the asparagus with some lemon and just try that and see what you think, right? And then they could come back to me and I have the time to do it. And that's the best thing about direct primary care is that you have the time to actually engage and concentrate on the foundation of health, which is these lifestyle habits that they can that change people, that actually change people. So that's how I kind of started doing it.
As you've gone on and talked to your patients about, hey, there's other things that we can do that are lifestyle changes in place of taking a pill as a prescription for your health, how do you benchmark these achievements to make sure that your patients are realizing and recognizing that they have done amazing things for their health because of lifestyle changes?
Yeah, yeah. So one of the things that you can do is kind of recap either at the beginning or at the end of what's going on, right? Because there's six pillars to these lifestyle medicine, right? Um, so there's like mindfulness, nutrition, exercise, sleep, social interaction, and then avoidance of toxic substances, right? And the biggest one that we know as physicians is that avoidance of toxic substances, right? Like alcohol and smoking, all that stuff. So I keep a separate area within their chart that's like a note that says, okay, here's the lifestyle medicine stuff they're going through, here's the plan they're on. And then my course also kind of tracks it too. Like I can see like where they're at. And then I can offer advice or talk about, let's say that module that they took, right? Or that they listened to. So that's how I kind of do it. And then you got to really ask like open-ended questions, right? You got to ask, well, how did you approach exercise when you were younger? What did that look like for you? And then they describe it, and then you understand what they're familiar with, right? Some of them will tell me, well, I always went swimming when I was younger. And I said, well, do you think that's possible to do it again? And then what I'll do is I'll find a gym that has a swimming pool in it and be like, hey, you want to go try this? And I'll include that in the plan. I will include the specific gym with the phone number and be like, hey, this is this is where it's at. If you want to relive your childhood, here it is, right? Um, and so that's how I approach it. That's how I kind of keep track and you always congratulate them, right? Like always fantastic, like that you did this. This is amazing. And that way it's a reinforcement to them that they may not have experienced from their last doctor. And that's why a lot of them show up is because their last doctor was probably so jaded by the system that they didn't give them the appreciation that they were looking for. Or the yeah, that's pretty much it.
In terms of you bringing this highly personalized way of practicing medicine, you're a DPC doctor, you have the time to do it. How did you set your pricing for your clinic so that your pricing would be able to support what you're doing so that you could continue on at your DPC?
Yeah, so took the approach of what we do with our medications, which is start low and go slow, right? So I started as low as I thought that I could possibly do it. And I looked at the map of the like the economics map across the county, which you can look at. I think there's a website you can go to and look at and where I got it from. And plus, if you do online mailing, sometimes they will show you the financial areas. And so they're like, if you want to send a mailer here, it's going to cost you more because it's a higher financial area, right? And so I kind of looked at it and was like, oh, okay, the area could support these pricing. And then I decided, well, if once I get a certain amount of people, maybe I can go up by $5, right? If I need to. And so that's how I kind of approached it. And I work backwards, of course, right? Start with how many patients you think you finally want, and then take a percentage distribution for how many patients you might have, and then multiply it by your subscription. And I actually used some data about the average percentage of patients that a normal DPC practice has, like the age range. And then so I priced it out and broke it down on those age ranges too. So
Gotcha.
yeah.
Excellent. And now, what about in terms of deals? People have deals like join free for the first 6 months, and then, or excuse me,
Hmm.
no membership fee if you apply before this date or whatnot. For you, you had, if a person buys an annual membership at your practice, that they would get 2 free months. So how did you see this particular deal affecting the growth of your practice?
So the deals didn't really seem to that deal didn't seem to matter. What mattered was if your friend joins, then you both get a month free. So that was really good because a lot of times, and I do it for like, married couples too, right? If the wife will be sitting there and the husband's there for the visit, and I say, well, if she joins, you both get a month free. And they're like, oh. And so then they would join, right? So that deal was a lot better. Another one, I did one, I think on Christmas, maybe. There's a Christmas December one that I ran. I think that's the one you're talking about. I think that was a 2 month one for there. And I don't have a like a sign up fee, which I remember I'd heard you say that you use that because in the beginning you do collect a lot of things for people, and that's a lot of time, right? That's a lot of time. And sometimes they end up like leaving like a month later or something. So I've thought about adding that on like a join one-time fee, just because it is like a lot more work, like the beginning visit, as well as collecting everything from their past history. So, but the buy one get or buy two get a month off is probably my most popular one.
Amazing. And I hope that that is helpful for other people to hear. I definitely will say yes in terms of why we added a sign-on fee to the practice is absolutely to support the work that needs to be done
Hmm.
prior to even seeing the patient. But also, if you're not opted out of Medicare, it's one way to ensure that a person has secured their spot at your practice, because that's not a billable thing to Medicare, is that's not a covered service in Medicare's eyes,
Oh
this
yeah.
fee to join the practice. And so for all of my Medicare patients, because I hadn't opted out until probably 2 months after is when my papers went through,
Mm.
after opening the practice, I had all of these people who I knew they were going to be members as soon as I had opted out, because they had paid their membership, their sign on to the practice fee. And so that was really helpful, even just to get some little income in the beginning to also pay for the EMR, pay for all
Oh
the
yeah.
things to run the practice. So something to think about, especially if you're thinking about, do I or do I not charge something? And another thing I think about is it also, Dr. Niti Kapoor has talked about this in her initial interview, the very first interview on this podcast, and then on her Patreon community interview where she gave an update to her practice, how putting skin in the game, it really matters. Like it
Hmm.
really, it shows the patient that like it is the patient saying, I value this practice to the point where I'm starting to invest in it right now. And it
Yeah.
shows the doctor that, like, wow, I have people who are like, they understand what I'm doing. They might not understand it fully, but they understand the
It's
idea that they're getting
yeah.
a private physician for themselves. So I think that it is definitely something to consider if people are listening out there and are like, I don't know which way to go. But I don't think there's anything wrong in not charging a fee. It's just that those are my reasons for sure.
Hmm.
Um, so now I want to ask you about employees, because you have employee offerings where not only do you have this on your website, an employee health for business offering with 2 to 49 employees, you also have a testimonial from one of the employees who you've taken care of. So I want
Hmm.
to ask you first, when you set the numbers, I mean, you've demonstrated how already you're very good at paying attention and respecting your own boundaries. But from 2 to 49 employees, how did you come to that number versus like, hey, whatever the employer has, I'll take?
Yeah, yeah. So that's just around the insurance requirements, because at past 50, like 50 and above, the employer has to provide insurance to those employees. And that's a totally different kind of game, which I didn't know about. I was like, oh, I'll just go and offer my services, right? But it turns out that if you go for 50 and above, you're probably fighting against a broker or somebody like this. And as as one of the benefits advisors told me, he was like, well, a broker makes you a broker, right? And because their payment is tied into the insurance like fee, like monthly fee, right? And so that's why I first put that up. But I recently am kind of going to join with a benefits advisor or benefits company that does DPC, and they do it really nicely and altruistically, and they've have a lot of success cases where they've saved people so much money, even including hospitals, where now the employees get free x-rays, they get free generic meds, they get free visits to their primary care doctor, right? Because they can literally save so much money by not taking the bigger insurances and just going like self-insured with direct primary care, that it changes the complete financial dynamic for them. But I start out the small companies because of that reason, the fact that I can give them care, and what they look for is like the high quality care. Like they just care that their employees are being taken care of because they have their own like business and they know these employees and they actually want something good for them, right? And I think they approach it that way versus the bigger companies approach it more from a financial kind of aspect. So that's why I kind of separated them out a little bit. And I just haven't added on the bigger companies yet onto my website. But that's why I broke it down like that. Because if they're like 50 and under, I'm like, okay, let's concentrate on what they want to hear. Like they want to hear that I care about the employees and they want to experience it themselves, maybe. So I will give them a free month or two and say, hey, come experience it yourself and see what you think about it. So yeah, that's why I broke it down like that.
Awesome. And let me ask you now about the types of memberships at your practice. You have both in-person memberships as well as online memberships
Mhm.
exclusively. So, was this as a result of the pandemic, or what was it that brought those two offerings in particular to the table?
Yeah. So I actually took down the telemedicine one because at first I was like, oh, this might be something interesting and useful to offer, but I haven't really found that to be the case. Like even when I advertise for it, like on Facebook, I think that market is so kind of flooded, maybe my area it is, that it's not fruitful for me and not for my surrounding community. So I actually took that down, and in place I have my mindfulness course, like where they can see it. So that's what I actually did. But at first I thought, okay, this might be useful for people who live far away and who want to be treated for certain things, but then I didn't really feel that comfortable with it, at least just my personal opinion. And I felt that like people would rather be seen at least once. And so yeah, I changed it up. So I the business term is pivoted, right? So that's what I did.
And you have the freedom to pivot, which is amazing and how it should be
Mhm.
because, like you said, every one of us is different than the next doctor. And we should be able to practice in the way that our personalities and our desires are, our desires to do lifestyle medicine or obesity medicine or both of
Mhm.
them, whatever, a practice that allows us to have the autonomous choice to practice the way we need to bring our expertise and our passions to the table. So amazing. Now, what about in terms of services at your practice at Clear Health, in addition to a membership as people would think traditionally, like a family medicine membership, lifestyle medicine included in that, you also do offer things like ADHD screens. So I wanted to ask
Mhm.
about if the services that you bring, like the ADHD screenings, are those for both members as well as non-members?
Yeah, so I have them for both. And the way I came about this was in when I'm marketing, I would call or not psychiatry, but counseling services in the area. I would go meet with them, and like the first thing they would say was like, "Oh, do you do this evaluation? Do you do this evaluation?" Because they literally can't get people in to see a psychiatrist for 6 to 8 months, right? And so I started investigating it. I started researching it. I jumped on PubMed, and I was like, okay, what are the best types of screening things to use and what do the psychiatrists use, right? Like how can I learn about that and look at it? And it's what's really nice is that each of these screening ones, like the one of them is called Connors 4. One, it's online. So I can send it to the patient one, the mom, the dad, and the teacher. So I can do that. But not only that, the inventors of it are on YouTube and they walk you through everything. So they have a 2-hour lecture on it. on like how do you use these things very beneficially, right? And that's the other thing about direct primary care is you can then go down these avenues and you have the time to provide services that would otherwise be completely unavailable, right? Not only because of the time, but also because of the cost. So if I know a family who is down on their luck and they're having problems, I can then just say, look, this test is X amount, and I'll only charge you that for it, whatever, how much, just like the dirt cheap price, right? So that they can get it done for their child, then the child can get help in school, then they can get medication that will completely and utterly change their life. Because I had one kid that wants to get into MIT, and he was suffering from ADHD. And so that's how all this started. And he was like in a prep school and fantastic, fantastic kid. And so it got me down this avenue of what testing, what special tests do they use? And not only that, but what physical therapy does ADHD require? So this is something I'd never even heard about until I started investigating this and watching, like just fantastic YouTube lectures by the experts. And then I had one of them on my podcast. So I had like the leading world expert on my podcast, and I learned so much from him. And so I can do that and bring it in for the community.
Your podcast, Clear Health Podcast, perfectly paired with the name of your clinic, you've been able to interview people like Dr. Ferone, who I'm assuming you're talking about.
Yeah.
And when it comes to having a podcast out there, there definitely are other DPC doctors who have podcasts specifically about health topics, whatever they're interested in. But for your community, how have you been able to, you talked about your mindfulness course, how have you been able to also harness these interviews that you're doing on topics that you are going to be talking to your patients about? How have you harnessed your podcast to support what you're doing during clinic and after clinic?
Yeah. So one of the things I try and do is interview people around certain medical like topics. And the other thing is that it allows me to interview people in the community. So like I just interviewed an attorney who he deals with like estate planning, right? Like in kind of end of life care, basically. And so he was able to give really good insights about what's going on and how you can legally manage your medical trajectory, right? So, because you want somebody, something happens to you, you want somebody to kind of take over who can help you out, right? So that was a really good talk with him. And he's part of a set of attorneys that is like DPC. Like they're throwing off the corporate kind of veil there, not veil, but like the corporate structure and going individual. And he taught me about why don't you hold a meeting every month about DPC at a coffee shop or something like this. And so, getting a little bit off topic, but the podcast allows me to talk to and reach people in the community that I probably never would have before. So it's like an avenue, right? Like into it's like a free ticket, right? Like it's a free ticket on that to that ball that you want to go to, right? and and it allows you to connect with them and learn insights you would never ever think about. Like I remember Dr. Frown, he was like, pills don't build skills. Even if they take the medication, they still have to build those skills to help themselves out. Mind-blowing things like this, right? So that's how I've used it to kind of leverage stuff. And one of the things I do is my software that I can send it out on the emails that announce, hey, here's another podcast. I can see them who opens it. And my last three or four, had 100% open. And then the click through rate was high. And so I'm like, okay, it's actually useful to them. And it must help them out at least. I don't have a million downloads yet, but I'm working on it.
I think it's great that when you look at different ways of reaching the community, like we talked about your outcome of the Healthy Expo versus the outcome of you talking with an expert in their field and
Hmm.
having it be pertinent to the community. I think it's definitely something for people to think about if they're also wanting to reach people and they haven't found that one way is helpful for their community. There's other people who they've tabled and they get people signing up. Fantastic. But I would say that this is where, again, doing what works for you is the way for sure to go. So amazing. Now, something that I thought was very cool that I loved learning about, especially having recently lobbied in DC for DPC,
Hmm.
you have been in addition to being a physician, you have written medical policies for nonprofit children's organizations. So I wanted to ask about how did you even get involved in doing something like that? And how
Yeah.
can you give us some examples of policy you've written?
Yeah, so it was actually an association run by the lady who cuts my hair. And so she started up I think it's called PBJ for kids or something like that. And she started up this organization. And one day she was like, what did she say? She was like, well, I think we need our medical policy rewritten. And I was like, oh, okay, I'll look into it. So I looked at the American Association of Pediatrics and I said, well, what needs to go into this, right? And then I cross-referenced that with the state laws of Michigan. Because before I did like 10 years in patent litigation as like a patent agent, not an attorney. So I was like, I know to look at the laws and then you cross-reference with the current like accepted social norms as well as accepted policies of like the guiding institutions, right? Because a lot of times when like laws are made, they're like kind of looking at like the American Heart Association, right? They're like, well, how do we build laws around what they find useful and things like that? And so that's what I did. So I just cross-referenced those two and I wrote probably 3 or 4 pages. And it was funny because you can see where they hadn't written policy or they copied it from like another older organization who never went back and looked at, hey, what's the new updated laws and policies around this, right? So I would see like old medical advice and be like, no, that's probably not the best thing. But then you write things like the child needs to be seen by their primary care physician, and these checklists of things are advised, and they need to be seen before arriving at the camp. Then all the physicians, all of the kids need to be screened as they enter the camp, right? But to check for diseases like lice and things like this. So that's how I kind of rewrote it like that. And I did it for free because she was my friend.
When it comes to policy and how to write policy that is protective of the autonomy that we have as DPC physicians, you're in a state, I'm in a state where we don't have this, but you're in a state since 2015, Michigan has had a DPC law on the books. And
Mm-hmm.
for you, you've met with people in lawmaking. You met with Representative John James.
Yeah.
And so I want to ask about when it comes to advocating for DPC, how would you recommend people represent it so that if it is not yet protected by policy, or if people are looking to protect it with policy, how do you recommend people think about or describe what we're doing so that policy can be written that protects, again, this autonomy that we have because we've left fee for service?
Yeah. So one, it's helpful to do research on the politician, right? What are their views? What do they see? Do they want more individual choices or do they want more collective choices? Are they like pro business? Are they not pro business? And what experiences maybe they've had in their life. So you can frame the position, kind of frame it around that, right? Like you have to meet them on a personable level a lot of times. And that's the first, like the first introduction thing, right? If they had somebody who, God forbid, passed away recently, describe how the the lady that was taking care of your mom or your dad, maybe she had to be replaced, and now that familiar face is no longer there, right? That familiar face that was there for your father or mother, and now that they're no longer there, they have anxiety at the end of their life. They're being taken care of by a stranger, right? And so describing it from a personal event that occurred helps a whole lot. So that's usually the reason why they're making the policy. A lot of times the one who made, you know how we had to check maps all the time? So I talked with him, the politician made that, and he was like, "Well, I went to the hospital one day and nobody knew what meds I was on, right?" And I was like, "Okay." And I understand like your fight against the opioids and all that stuff. And so it's a lot of times it may be a lot personal for them, but then also alleviating their fears, right? Their fear is that, well, the doctor is going to take advantage of this situation of not having to report themselves. So it's just going to be another Medicare fraud situation again, right? So this is kind of running in the back of their head sometimes that these things will occur. So you have to alleviate that. And then at the end, also the finances of it, like the financial projections and the financial examples that you can give them can really help because a lot of them don't like when the doctor leaves the state. And because unfortunately in the insurance-based world, that means that Medicare money leaves with them, right? Or that it just goes away with them. So even just a doctor leaving to go somewhere else where that state is pro DPC, then that raises a little bit of their alarm bells. So those are some of the cases that I've run into, like as far as approaching them like about policy and stuff like that.
When you look back on your journey, and when you look back even prior to becoming a doctor and you were playing guitar in a place where you were still making a difference, even though you weren't at the time participating in the medical care of people, the medical decision making of people, I
Mhm.
want to ask about this humanism in medicine. And I want to ask if you can share with the audience words of encouragement for those people who are desperately wanting that humanism in medicine or wanting to increase how they deliver that humanism in medicine.
Yes. So all the time that you are spending now learning about medicine, you're learning it at an extremely high rate. And it's unfortunate that in our world, that kind of excludes the human interaction because a lot of times human interaction manifests through time and over time. And right now, you don't have a lot of that. But what you do have is the experiences of being a doctor, and you have the experience of suffering. And that suffering can then be used and turned around as the reason why you're doing what you want to do. So even though it exists, you're still in transition, right? You're not stopping moving. You're not probably always going to be there. If you're looking forward to get out of DPC or into DPC, then you're simply on a transition point. You're on a train to not even a destination, but a next kind of understanding of what medicine is and what it should be. So I would definitely say keep your hopes up and plan just a little bit every day and keep listening to really good stories.
With that, thank you so much, Dr. Rountree, for joining us today and sharing your
Yeah.
story.
Thank you so much, man. It was fantastic talking with you. You brought a lot of things I wasn't too sure about, but I had a great time. That's for sure.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.